A ideia desse simpósio surgiu meio que de repente de uma situação de congresso. Né? Eu conheci Daniele em Viena, num congresso que teve lá de psiquiatria biológica, o ECNP em Viena, e, coincidentemente, no início do ano, recebi um e-mail do Leonardo Fontanelli, que estará aqui com a gente em maio, dizendo que Daniele Catti viria para um casamento de uma prima, aqui em Porto Alegre, e perguntou se, de repente, poderia conversar com a gente, fazer alguma palestra, alguma coisa das coisas que o pessoal pesquisa lá na Universidade de Utrecht, né, na Holanda. E eu disse, nossa, como não? Né, conseguimos combinar o horário, tudo, né? Então vejam como network é uma coisa que funciona em congresso. E, aliás, se alguma coisa boa acontece em congresso, são justamente a formação dessas redes, assim, né? Conhece pessoas. Eu conhecia ela de nome, pelos papers, pelos book chapters, né? Mas não conheci ela pessoalmente. Conhecemos pessoalmente, né? Estamos aqui agora para ouvir. Utrecht é uma cidade próxima de Amsterdã. Eu preparei uma apresentação, mas não vou colocar ali, né? Para mostrar como é que é Utrecht. Bom, é uma universidadezinha pequena, minúscula, tem só 30 mil estudantes, cerca de 5 mil entre funcionários e professores. Eles têm nada mais, nada menos do que 10 prêmios Nobéis. É uma universidade relativamente nova, que nem a nossa, que ela é de 1636. E eles têm prêmios Nobéis relativamente importantes, assim, como vitamina B1, né, a causa do beriberi, o cara que estudou toda a fisiologia do eletrocardiograma, e o Röntgen, que é o cara que descreveu, desenvolveu, descobriu o raio-x. Eu peguei só os médicos, assim, tem muito prêmio Nobel em química, física, então uma universidade grande. A Daniele Catti é psiquiatra de adultos, ela é professora do departamento de mental health, digamos assim, né, psychology, psychiatry, e ela trabalha principalmente com genética epidemiológica. Então, uma das coisas que ela vai apresentar aqui para hoje, para a gente, vai ser justamente sobre epidemiologia genética, principalmente quando a gente fala de uma parte mais clínica, assim, agregação familiar, e questões de ganhos cognitivos, especialmente em transtorno de ansiedade. I was introducing Utrecht, like you say, and a little bit of you. So, we are going to listen to Daniel, and afterwards we have two commentators. First ones are going to be Ana Luisa and Carolina Blaya, and afterwards me myself. I have invited the people from genetics area, but I think they got some kind of shame because of the bad English. Not everybody here speaks English, but you can speak English. If you try to speak Dutch, I'm afraid the people are going to run. So, okay. Welcome to Porto Alegre. Welcome to Universidade Federal de Ciências da Saúde. I think I need to give some words to Dr. Ayrton, our prorector, and afterwards I think we can start. Yeah, and if Dr. Helena is going to talk, yeah. Thank you, Dr. Ayrton, for being here.
Yeah.
The new prorector research.
So thank you for accepting the invitation of our university. It's an honor. And I would like to share with you one topic that it came to my alert as researcher mobility. Brazil's active researcher population is quite sedentary. 62.9% of Brazil's researchers have not published with an affiliation outside the country. So this is one of the major problems that we have in our research community. So people like you joining the group of psychiatry in this university will improve the mobility of the researchers in our country, and the rate of sedentary researcher in Brazil is around 63%. So most of the researchers don't publish with researchers from outside the country. So it's quite relevant, this kind of meeting, to stimulate network. So thank you for being here, and I'm sure everyone will improve their research status.
Well, thank you very much for, well, actually, I've also a little bit invited myself to this to this congress, and that is because I have a cousin here. My mother is actually from Brazil, and it's really a shame that I don't speak Portuguese. I speak Spanish, but no Portuguese. And one of my cousins is going to get married tomorrow. So I thought I'm in the way for my family because they're having all these preparations. And so why shouldn't I work a little bit? And that's why Leonardo and Igor and I were thinking, and I thought, well, I can come to the university to give some talks. I'm a psychiatrist, and actually at the moment I'm the head of the specialist trainings in the north of the Netherlands, and I have an appointment at the University Medical Center in the north. It's called Groningen, which is a horrible word. We have a horrible language compared to your language. And I'm also having an appointment at the Department of Clinical Psychology at the University of Utrecht. And that's because at that department, there's a lot of anxiety research going on. And my specialization is in the field of anxiety disorders, but also in the field of OCD and tic disorders. So I'm a bit switching from one field to the other from time to time. And today I'm going to talk, because that was actually what you asked, about pharmacological enhancers of anxiety disorders. And then after the break, I will talk a little bit about genetics of tics and OCD. So there's something for everybody in, and I hope you will enjoy that. Can I have the next slide? Well, this is not a very interesting slide. It's about my disclosures. Can I have the next one? And also the next one? Yeah. No. Okay. So to start talking about cognitive or neuro enhancers or pharmacological enhancers, those are three definitions that are used interchangeably. Why actually, what would be actually the idea behind it? Why do we need those? And that's actually because the effects of our therapies in anxiety disorders they're okay. They're not worse than they are in the somatic field. We must never think badly about the effects of our therapies of the psychiatric disorders, because they really, although many people are not very satisfied, they're really not worse than they are in the somatic field, but still it's suboptimal. So what do we get? When a person is suffering from an anxiety disorder, it's about, we don't know which proportion, but at least in the Netherlands, there's really at least 20 to 25% who refuses to start pharmacotherapy, who says, no, it's something of my will, and I need to overcome it in a different way, and I don't want pharmacotherapy. Then there's about 24% who drops out from pharmacotherapy prematurely. And then there is 30 to 50% who doesn't show clinically significant improvement. So, well, they get a little bit better, they sleep a little bit better, but you think, wow, I'm not really satisfied. And then there's another problem. So we have in the end about 50% of our patients who really improve on pharmacotherapy, but of which more than 50%, if you stop the pharmacotherapy, relapses within 1 year into either the same anxiety disorder or another anxiety disorder, or depression. And that's really impressive, how many people relapse if you stop the pharmacotherapy. Can we go to the next slide? So, okay, let's say this is pharmacotherapy, but I don't know about the guidelines in Brazil, but the guidelines in the Netherlands and also in Europe are that in anxiety disorders, in the less severe cases, you can choose together with your patient whether you start pharmacotherapy or cognitive behavioral therapy. And in the more severe cases, you start with a combination of cognitive behavior therapy and pharmacotherapy. How is that here in Brazil? Same situation, yeah. So, but when you look at CBT, we'll call it cognitive behavioral therapy, you see the same picture, about 20% who refuses, who says, no, 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 I'm not going to practice in all those fearful situations. And then you have about between 15 and 30%, a little bit less than in pharmacotherapy, who drops out of therapy. Then no clinically significant improvement in 50%, and in the end you can there's also again this relapse. So there's really a problem that we're having. Can I have the next slide? So what is actually a classical anxiety conditioning and extinction learning? That is the basics of our therapies. What is actually the idea? I don't know. In the old school, we thought that when we do our cognitive behavioral therapy, because this talk is about enhancers of cognitive behavioral therapy, we thought, for instance, you have been in a bus, and in the bus you have witnessed a car crash. So for some reason, being in a bus, which is a neutral stimulus, gets associated, coupled with this aversive, horrible situation that was really emotional to you, witnessing a car crash. So the next time you want to go with a bus, you have this memory of the car crash, and you start thinking, I'm going to avoid the bus. So this coupling of the neutral stimulus with the aversive stimulus has taken place. And what do we think? Can I have the next? Yeah. What do we think by doing our CBT is that we decoupled the bus with the car crash. Actually, what we think now is that that's not the case. Can I have, yeah, next slide, please. What we actually think that extinction learning is about, in the new school, it's not about habituation, so that you, by practicing, you decouple more and more and more. No, it's inhibition learning that we have. And inhibition learning is actually the situation, what we think is that the old association of memory of the car crash is still there, but you strengthen new experiences, new associations. And in the end, the strengthening of the new association wins. That is what we call inhibition learning. And has anyone of you heard of Michelle Kraske? I think so, most of you. She's very, very famous. And she's actually the one who is behind this, all kinds of experiments that have shown this. So this is very important to understand what we do with our exposure therapy. What it means when people say, I have a decrease of my symptoms, it means, okay, I still have this old thing there. That's why people relapse so often and so easily. But I have this new experience that's stronger than that. And that teaches me to overcome my fear. Okay, can I have the next slide? Next one. Yeah. So what do we do with our neuro enhancement? Actually, we want to decrease these, well, actually this is, yeah, the idea is that we want to influence this process of inhibition learning. And the idea is, it's also a new idea, that fear memories are changeable. That fear memories can be strengthened by putting something in that's called a cognitive or a neuro enhancer. And and that you can change that during the process of extinction learning. So there's a sort of a golden hour in which you can influence it. Okay, next slide, please. So what is going on? You do this through a process called memory reconsolidation. Have you all heard of that? Well, that's actually the process. And actually, memory reconsolidation means a change in the fear memory. So you learn, you go into the bus and you learn there's not going to be a car crash. There's going to be nothing. I can just sit in the bus, look outside, and nothing is going to happen. That is learning a new memory that is being associated with a bus ride. So this change in fear memory happens in two phases. It's a short-term phase that takes place within hours to perhaps at the most 2 days. It's a synaptic change that you have there, and you have a long process in which it calls a systems consolidation, in which the fear memory that was first in the amygdala and then in the hippocampus is going to be transported to the cortex, to the ventral medial prefrontal cortex, to be more precise. And that is a phase that takes place in weeks to sometimes years. And that causes a stable fear memory. So you have a label fear memory and a stable fear memory. And the neuro enhancers, they work on the label system, not on the stable system. So, yeah, and here, so if we look at that in more detail, you have witnessed this car crash, you are in the bus, and you have, and you acquire fear, and that is in a process called short-term memory consolidation. It's these hours to days phase. And then in a more longer process, it gets transported to your cortex from amygdala and hippocampus to the VMPFC. And it's a long-term consolidation, and it acquires a stable state, and it leads to fear behavior and avoidance. Then we come in as therapists and we say, okay, we're going to change this. We're going to replace it by more, by neutral images. And then actually you introduce again a label state. You change, and you add these new fear memories, and that you hope in the long end to stabilize that. Okay, next slide. Next slide. So in this, what I was saying before, in this neuro enhancement, you have this window of opportunity. And this window of opportunity is around your exposure sessions. And we call it, again, the golden hours of neuro enhancement. It's in those labile states. It means in the consolidation phase. So that is also the tricky part. When you have an exposure session in which a patient gets more anxious instead of less anxious, then you have a problem with your neuro enhancement, because you will enhance that as well. But normally, your neuro enhancement is in the phase of the fear extinction process. Okay, next slide. So what are the newer enhancers that we have? We have a lot of them. They all work through this crucial system. Okay, next slide. And today I'm going to talk about 3 of them, and that's because those are the mostly investigated ones. It's D-cycloserine, on which actually in Brazil you have done quite some research, and propranolol and cannabidiol. Okay. D-cycloserine is one of the mostly tested of all enhancers. There have been more than 60 human studies and more than 300 animal studies performed on it. And actually it is originally, it's an antibiotic. And it's still being used to treat tuberculosis. I don't know whether any one of you has ever treated people with D-cycloserine, but it's used a lot. And it has been first tested in rats. And actually it is actually a drug, an enhancer that has been chosen by the scientific people based on its working mechanism. So it has not been a chance finding, but it's really been chosen. They thought we need a glutamate agonist, and the D-cycloserine was one, and then they said, let's test it, especially in low dosages, because in high dosages it's actually an antagonist, but that's another story. I talk about the low dosages of D-cycloserine. And it was tested in rats who were fear conditioned with the light shock paradigm and then unconditioned with extinction training. And the extinction happened to be faster when DCS was added. Okay, next slide. How does it work? Next slide, please. I think this is more clear. It works actually by stimulating the NMDA receptors, and actually by stimulating NMDA receptors you stimulate glutamate activity, but this stimulation is dependent on a coenzyme, and this coenzyme, that is actually what D-cycloserine is activating. So it's actually a very indirect activation of glutamate receptors, or of glutamate activity through the NMDA receptors. Because as you all know, glutamate is a central excitatory neurotransmitter. If you give that directly, boom goes your brain. You cannot do that. And that's why we give D-cycloserine, because it's a softer, a more indirect pathway, which still stimulates glutamate activity. Okay, next slide. So, and what does it do? Again, I had this whole consolidation, reconsolidation story, and what we think, it enhances fear extinction learning. It enhances reconsolidation, and it does it through these NMDA receptor stimulations in the amygdala and subsequently transporting it through the hippocampus to the VMPFC. Okay. Next. So the effect, yeah. Oh. The effect of D-cycloserine is short. It doesn't have an effect without exposure and response prevention. So you really have to do something. You have to put people into an emotional state in which they are starting to learn, and then it has an effect. It does not have a direct effect on learning, because otherwise people would, like you, if you have an exam, you would think, why don't I use some D-cycloserine? No, it's not going to help you. It is coupled to extinction learning. So not to just cognitive learning. And it has a context-specific effect in rats. So if you put rats in a certain cage and you give D-cycloserine, it helps. But if you put them in a completely different situation, you won't see that same effect. It's very interesting. Okay, now what about studies in humans? There has been a first meta-analysis. Yeah, can you? No, go on, because, yeah. Okay, thank you. And everybody jumped on this meta-analysis because they thought, well, this is wonderful. So it was a meta-analysis by Norberg, who included a lot of animal studies and the very few human studies. What do you see here? Size, that was very reasonable. That was about 0.6. Do you know something about effect sizes, what they mean? Little bit. What is an effect size of 0.6? Is that a large effect size or a small one? It is okay. It is a moderate effect size. Eh? But what do you see? So, but everybody thought, well, if it has an effect size on top of the already large effect of an exposure treatment, then it's not a bad idea. But what do you see here? You see there an effect size in animals, that's the large, of 1.19. But what you already see in humans, it's much smaller. It's 0.42. And I think we have overlooked that difference between animal studies and human studies. It's much larger in animals. And here you see the same at follow-up, same 0.20 in animals, now 1.20 in animals and 0.29 in humans. But it really encouraged a lot of human studies. And then what happened? Can I have the next slide? We performed an RCT, a randomized controlled trial, in patients with panic disorder and agoraphobia. And we had 3 groups, because the idea was, actually, we would like to test, first of all, whether D-cycloserine works, but secondly, whether it would work equally well if we give it directly after exposure sessions, as if we give it before exposure sessions. Because if you have had a bad exposure session, then you can decide as a psychologist or psychiatrist not to enhance. That would really have an advantage over always enhancing before the sessions. Can you imagine? So we wanted to find that out. And what we think, so these golden hours of memory reconsolidations, they happen between 2 hours and about, well, 1 night in between, because a lot of reconsolidation occurs in sleep. So up until 1 day after. So if we give it directly after the session, we are safe. We are at the safe side. So what we did, because it also has a short lasting effect, we said, okay, we'll give it during 6 sessions, and then we'll have an additional 6 sessions if needed of treatment as usual. And let's see what's going to happen. And we really focus on decrease in agoraphobia. What happened? Well, okay, this is what I told you. Next slide, please. What did we find? And please, can you add the other one? Yeah. What we found, so these are 2 outcome measures. It's the mobility inventory. It tests how much you can do alone after your therapy. And the one is the panic disorder severity scale. And what you see is that the placebo, the placebo condition is the green bar. The DCS pre and posts are blue and red. And you cannot see that very well with the MI alone, but you can see it on the PDSS, is that actually at follow-up, so at 3 months follow-up, we saw that D-cycloserine after the session was led to a decrease that was actually much better than before the session. But there was an additional problem, is that both conditions were not better than placebo. So in the end, we ended up with an effect size of the exposure session that was around 1, but actually no additional effect of D-cycloserine. Okay, next slide. And then we thought, well, this is actually the way that all the D-cycloserine studies have gone through. The next thing is there an effect in more severe subgroups? Because there had been a study by another Dutch group, by Rianne de Kleine, who found an enhanced effect in PTSD patients who needed more sessions. You see the white bars, you see that they actually end up very, very well in the end. Well, can I have the next? And what we found, no differences between fast and slow responders, no differences between those who needed more sessions or less. Okay. Then we read a lot from Jasper Smits about, he has published 2 papers that D-cycloserine enhancement is specific to successful exposure sessions in which the fear really decreases during the session and leads to lower subjective units of distress in the next session. Well, we looked at that. Please, next slide. This is what you see, but we looked at that in our sample. Next. No predictive value. We didn't find any relationship between success of D-cycloserine and successful lowering of anxiety scores. So that was a problem, okay. Then there was, from the same group again, there was a story about interaction between D-cycloserine and antidepressants, saying that if people also have antidepressants, that then D-cycloserine doesn't work. And it was really a high up study in JAMA psychiatry. We looked at that. What did we find? Next. Oh, this is actually the study really showing they have had internet CBT and they enhanced in OCD patients, and it really showed a Y-box score that was really much lower that in those people not receiving antidepressants, much better than those who received antidepressants. Well, we looked at that. No interaction. So actually our end conclusion was we don't find anything of everything that was reported. Then came a second meta-analysis by Rodrigues. That's a Brazilian. Where do you know them? Oh, and they found a very modest effect with a Cohen's d of 0.3, which is actually, it's not that bad, but it's more that you think, wow, it's not really good. Yes, next slide. And then in 2015, we had this third Cochrane review finding, so what you see is that the numbers go up. There have now been 21 RCTs, 4 RCTs in children, no differences between DCS and placebo, no differences in acceptability between DCS and placebo. That's also what we wouldn't expect because D-cycloserine has no side effects actually. And now the next slide, meta-analysis number 4, this year from David Matekols, and he also found just a very, very small effect of D-cycloserine, but all the things that we didn't find, so in these subgroups, they didn't find either. And actually, yeah, what does this learn? What does this teach us? It teaches an old research story. And it's a research story that people start with a new drug. The expectancies are very, very high. Everybody jumps on it. Everybody overlooks actually the very early warning signals of that it might be much less than we expected. And so with increasing studies, with increasing sample sizes, with increasing quality of the studies, you see that really the effects go considerably down. So that was the story of D-cycloserine. I must tell you one thing, in the United States, you have insurance companies in whom you can only get your CBT paid if you additionally use D-cycloserine, despite these results. But I hope that we are a little bit, keep our heads a little bit cooler here, because it's not a very good story. Although, well, the last word about this post, is any one of you studying D-cycloserine at the moment in your university? No? No. Okay. I would like to go to the propranolol story. Are you still interested? Yeah. Okay. Yeah. Okay. Yeah, next one. In Holland, you can get D-cycloserine in the drugstore, huh? But in very, very low doses. Okay. Propranolol has also been studied a lot. Propranolol is an adrenergic, so it's not directly glutamatergic like D-cycloserine, but it's adrenergic. It's a beta blocker, actually, and it has been used a lot in Holland to treat hypertension. And it has this peripheral effect on tension through the noradrenergic system. And centrally, it blocks adrenergic receptors in the amygdala, in the basolateral part of the amygdala. And it has originally been applied as a general anxiolytic, but it doesn't appear that good. And it has recently been tried again as a cognitive enhancement to decrease direct fear memory, which is of course very, very interesting. If you can find an agent, you have gone through a traumatic experience. You can find an agent that sort of blocks the fear memory of that experience directly after a trauma. That would be very, very interesting. So why do we think that? Next slide, please. There has been a study by Merel Kind from the University of Amsterdam, a psychologist in Nature Neuroscience. That was a very high up publication. Everybody in the Netherlands talked about it. And it was called Beyond Extinction, Erasing Human Fear Responses and Preventing the Return of Fear. And everybody thought, wow, this is going to be it. And the hypothesis was that beta blockers during fear memory consolidation in these golden hours, that it strengthens protein synthesis in the amygdala during consolidation. So that there occurs deconsolidation and fear memory does not occur. And only the declarative memory, so only the actual talking about what happened remains in the hippocampus, but not the emotional memory, just the actual memory. Okay, next slide. And what did they found? So they gave to healthy subjects, they gave 40 milligrams propranolol or placebo, and they did an anxiety conditioning paradigm, so an experiment in which you give shocks and you pair them to light or to non-light or to visual images in one day. And then in day one, and the next day, they gave propranolol or placebo preceding the reactivation of the memory, asking subjects the same thing again. And at day 3, they did an extinction paradigm and a reinstatement. It means having the fear memory come back paradigm. And what they actually found was in the reactivation phase in day 2, that those people who had received propranolol, that they actually had no fear memory at all. So this was, it is actually a very elegant trial. But it was so in normal, healthy individuals, not in patients, not after real traumatic experience. Actually, this is mostly what psychologists always start with, in normal people using an experiment. Next slide, please. But okay, this has been in healthy subjects. Let's go to the next slide. So what happens to patients with post-traumatic stress disorder? Can propranolol influence their memory consolidation so that it gets deconsolidated? And can it influence in the long run, when people already have a PTSD, influence the reconsolidation processes? What has been done, it has not been very well studied, actually. I was really amazed about how little I could find of the literature on patients, actually. They have, in patients, there have been several experiments directly after trauma, one single gift, directly after trauma, longer periods of propranolol, in patients, propranolol during exposure, and in healthy subjects preceding trauma. Well, that's impossible. So that's also is also possible, only possible in these experiments with shock and lights. Okay, just another, yeah. Oh, here. In this experiment, 41 patients have been given propranolol or placebo for 10 days during their exposure therapy. And what you saw, the only thing you really see is that there's a little bit less physiological response at imagery after 3 months. Yeah. That's actually the only result we got. Yeah, can I go to the next slide? Then there has been a meta-analysis in which there has been tried propranolol at outpatient services, so at the acute departments. This is very interesting, in which they found relative risk to be very, very little lower when they gave immediately after trauma propranolol in one gift. But it's not at all impressive. It's a non-significant finding. It's a little bit less than 1, the relative risk, but non-significant. Okay, next slide. Then finally, there was a study last year by Thomas, who was interesting to what extent propranolol preceding or directly after a retrieval emotional memory would be effective. So he gave a series of emotional slides and of normal slides to normal subjects, and he administered propranolol either pre or post these slides. And what did he find? He found, yeah, no, sorry. What he found, this was post, he didn't find any difference between propranolol and placebo, but pre, he found some difference in what you see in the black bars, is that at week 2 and week 3, there were less correct answers on the emotional pictures that he presented. So there might be, yeah, next slide. So there can be from propranolol some effect on physiological arousal, at script-driven imagery, or some effect of in potential patients if you administer propranolol preceding a traumatic event. But this is really a very difficult experiment. And you know what the experiment is that I would be waiting for with propranolol. So giving it after a traumatic event doesn't seem to have much significance. But I would be very interested in looking at the large number of patients who receive beta blockers for their hypertension, and whether they might be a little bit protected against traumatic effects in their lives. Never been studied. That would be really, if you in Brazil can see if you can have access to some case register or to some, that might be really of interest. Okay, and the patient studies up till now. So this is the story about propranolol. Now I end with cannabidiol. Yes. Actually, I can't help it, but I'm very enthusiastic about this. Yes, Swarji. Yes, you do. There's a lot of Brazilian studies. Yeah, there's Swarji. No. But listen, this is the story. Wait. Cannabidiol, it's we are talking about cannabidiol. What is cannabidiol? Yeah, listen, it is part of cannabis. Okay, cannabis has more than 60 cannabinoid molecules, but the 2 most important of them are tetrahydrocannabinols, or THC, and that's actually responsible for the high effect of cannabis. The other component is cannabidiol, and that has an antipsychotic, anxiolytic effect and no high effect at all. And actually, what we are interested in is not the THC, because it has a lot of problems. It gives a lot of problems, but in the cannabidiol. And actually, what does cannabidiol do? It indirectly stimulates the cannabinoid 1 and 2 receptors. And well, I'll come to that in the next slide. But the point is, in the Netherlands, we have a lot of problems currently with cannabis in the Netherlands, because in the past 10 years, the proportion of THC towards cannabidiol has more than 4-doubled. So in the old days, there used to be THC and an equal amount of cannabidiol, of which we know that it has reverse effects on each other with respect to the salience system in neuroimaging studies. But now the proportion of THC is very high and the proportion of cannabidiol is very low, leading to a lot of psychotic symptoms and a lot of problems. And next slide, please. But what does cannabidiol do? It interacts with the mesolimbic dopamine system. Again, you have this same system, the ventromedial prefrontal, the amygdala, etc. It's the hippocampus, basal ganglia. And what does it do? It blocks the Fa enzyme. And the Fa enzyme is responsible for degradation of a neurotransmitter that I had never heard of before I studied this cannabidiol. It's called anandamide. And you know what ananda means in the Indian terms? It means happiness. So by blocking this Fa enzyme, it enhances availability of anandamide. And anandamide stimulates the CB1 and the CB2 receptors, and those receptors interact with dopamine. So there you have the circle around. So it's a dopaminergic drug again, like actually in a way like dicycloserine, but with a completely different working mechanism. Okay, can I have the next slide? What are important facts about this? So about this cannabinoid system, especially with respect to CBD, to cannabinoid. CB1 receptors are expressed in the brain. CB2 receptors are expressed in the immune system. And we are, of course, predominantly interested in the brain system. It enhances the extinction system in the basolateral amygdala. What you find in PTSD patients is reduced levels of these endocannabinoids, and it regulates synaptic plasticity. This is all very important. Okay, let's go to the next slide. And so it is also already for a long time, it is already known that cannabidiol has an anxiolytic effect. And the firstly, it was of course studied in rats by Betancourt, and he did a contextual memory test, and he gave either placebo or CBD. And what did he found? Can you get the next? Yeah. Oh, especially he found here that actually the freezing time in rats was considerably lowered when the rats had cannabidiol preceding this contextual memory task. And that was both in the short term and in the long term. So if you put the rats again in the same situation, you got the same effect. Okay. Next slide, please. Oh, this is still in. Well, if you see about human studies, what you see is that CBD has an anxiolytic effect and it's antipsychotic, okay? And it reduces the euphoria caused by THC. Next slide, please. There has been one study only, a randomized controlled trial today in psychotic disorders. No other randomized controlled trials have been performed. And this was done by Leeuwenke in 2012. And what he did, he gave to psychotic patients, to 20 of them, he randomized them to cannabidiol and the other 19 to sulpiride, dogmatil. I don't know whether you prescribe it here. You might. It's an antipsychotic, it's a D2 antagonist, and in lower dosages it works presynaptic and in higher doses postsynaptic. And he gave them both 800 milligrams, amisulpiride or cannabidiol. And actually he would have liked to give it to more patients than 40 to 80, but most of his psychotic patients, they were smoking cannabis, so he couldn't give them, put them into this trial, and then the trial money ran out. It's all in the paper. I found that a very honest paper, actually. So it's a little bit underpowered, but what did he find? Next slide. Can you, and I think, no, go back to this slide. What he actually found, he found that cannabidiol and amisulpiride were after 14 and 28 days on several parameters. So the PANSS scores, the change in positive symptoms and negative symptoms, it was equally effective. But what was the big difference between cannabidiol and dogmatil was that it had no side effects. And that is actually a very big advantage of cannabidiol. So now the next slide, please. Okay, what about anxiety disorders? There are only studies who have only given one gift of cannabidiol. Other studies are not available. And what did you find? There's one study by Bergamaschi, please. In social anxiety disorders or disordered patients. And what you find, and they were put into a speaking test, which is horrible for a social anxiety disordered patient. What you find is that those who received cannabidiol, that they were equally fearless as healthy controls. So the green bars are the healthy controls, the blue ones, the cannabidiol, and the red ones, those who received placebo, and they had a big peak in their speaking anxiety. So that is actually the only study that we have at this moment. Okay, can I have the next slide? Next slide, please. Next one. So what are we going to do ourselves? We are now conducting a randomized clinical trial of cannabidiol versus placebo in phobic patients, patients with social phobia or panic disorder. And we're giving them 8 times preceding an exposure session, 2 hours before. We're giving them either cannabidiol or placebo. Yes, next slide, please. And so this is a study that is ongoing. And we don't know the results yet. And hopefully this time we'll be more successful than with our propranolol and our D-cycloserine. And that is actually what I wanted to tell you this morning.
Thank you, Daniel, for your lecture. Gostaria de convidar agora a professora Helena Barros para coordenar a mesa. Vai dar tempo? Tem que sair? Ah, não. A gente vai cortar o intervalo, um pedacinho assim, para a gente terminar no horário, né? Gostaria de convidar então a professora Helena. She is the coordinator of one of our post-graduation programs, the most important, may I say? Yeah? may I say, the most important post-graduation program. She's going to coordinate the table. We are going to comment your results and make some questions. The audience can make some questions if you want, no problem. You're retired? 15 minutes to questions and 20 minutes, and after we pass to the other lecture. Okay? Can be? Okay, go ahead. Thank you.
Thank you, Dr. Igor, for the honor to be here with Dr. Danielle. Very illustrating and very thoughtful talk about different aspects in clinical pharmacology. We really appreciate you being here because this is the beginning or the continuation of this internationalization idea that we have in Brazil and we have been trying to implement. So I thank you very much for being here. Thank Dr. Igor very, very much to put this meeting, this one-day meeting up. So now we are open to questions and to commentators to bring up more questions and thinking about the ideas you're bringing it up here for us today. I want to start because I have the microphone. I specialize as a psychopharmacologist in drugs of abuse. And I really liked your little scheme showing that if I antagonize CB1 receptors, naturally the system, the endocannabinoid system, will try to overcome this antagonism, will increase the secretion, the release of anandamide that is our endogenous cannabinoid. I really don't know, and I would like to hear something about that. How much antagonism is needed to increase anandamide, the endogenous cannabinoid, so it will become also addictive? Because this might be the problem here.
Well, actually, we don't know whether CBD in itself. So what we give synthetic CBD, and we think that synthetic CBD is not addictive at all. It's the combination with THC that is addictive. There you get the problem. So actually, we have been struggling a lot to know how much CBD we should give to antagonize in the first place this for this FA inhibition system. And what we also do, we decided not to give it as a drug trial. So that's what you can do as well. You give 3 times a day for 2 months the drug, and then you see what happens to the anxiety. No, we decided to use it really as a pharmacological enhancer. So therefore, we don't have any fears of addiction because it's only coupled to your exposure sessions. Yeah. But I don't know the answer to your questions, frankly, but I don't think it is a problem with CBD. But I'm not sure.
Oh, that's the problem. It's a new drug. Everybody's enthusiastic, and I really liked your message. This is what we see all the time. Yeah. We're very enthusiastic. We have a new drug, and then we get lots of problems with it. Have to think it over.
Yeah.
So my name is Carolina Blaia. I work with CBT here in Brazil. And I'd like to congratulate you for the talk. It was excellent. And I have a list of questions, which will take, I think that I have at least 10 questions that I have. I have one idea and a project that I just created right here. But in order not to take so much time, I will ask you about, do you have any experience of or have you ever had tried something related to methylene blue as enhancement for CBT or for treatment? No, because I have seen that that there are some trials, and yeah, and we were trying to do one trial, but we were quite afraid about the side effects, so we didn't carry on. So, and what about ketamine and cortisol? Because for PTSD, I've seen some studies with corticoid administered just after the trauma, and I think that is also a good candidate. And ketamine, I've seen some studies that they gave the ketamine before the trauma, which is something that we can do here in Brazil because we have a lot of trauma. And I'm also interested in this, so I'd like to listen about these other options.
So I cannot tell you about that. Ketamine actually is a drug that we try in Groningen in the north in the treatment of depression. But what I find of ketamine has some problems. It is also that it has a very, very short half-life time, which means that it works out within 30 minutes or to 2 hours or something. That is, of course, a problem if you want. If your model is, we want to influence this memory reconsolidation during extinction learning. Huh? That's what I was trying to, that's a model that we use. We don't know whether how appropriate the model is, but it appears to be so. But then with your ketamine, you are, you're not very well off because of this very short half-life time. You have to be very quickly and be at the right time. And it also has a lot of side effects. So I don't know. We opted for a drug that has very little side effects. CBD has no known side effects, as opposed to THC. And we decided to really be pure and to use synthetic, so not hey. So perhaps because we're near to each other.
So let's change,
Okay.
and I'll move.
Yeah, but that's what. And cortisol has also, cortisol is typically cortisol has been tried a number of times, but mainly in studies with depression, and absolutely not with convincing results. And it works more through influencing the HPA axis. So that's a bit of a different model. It really acutely reduces stress. That's the idea. But our idea of influencing memory reconsolidation actually is that you have to induce stress during your exposure therapy, because then you better affect emotional memory learning, and then you go and influence it with your drug. So actually we have a completely, when I think of it now, it's a completely different paradigm. So I would rather opt for these kind of things. But ketamine, I must say, might be an option, but then you have to beware of all the side effects. Yeah. No.
They're going to stand up all morning.
Okay. Congratulations for your excellent and very clear lecture for us, and for your honesty. I work with dementia field, and I've expected a better effect of neurocognitive enhancer, at least in anxiety disorders, because in dementia we don't have. But I'm thinking about 2 or 3 questions. The first is, could the time of training or exposure affect your results? The time of training before cycloserine, the time of training, the time of exposure to the phobic situations, could this affect the results?
Well, it can, because what we saw in studies in which D-cycloserine has been administered hours before, like 4 hours before exposure training, then it had no effect whatsoever.
Okay.
So still, although people said we have administered it right before the exposure session, you never know what actually happens.
Oh, yeah.
So,
Okay.
but we trust our clinicians who administer the drug. But it's a good question because it can, and actually the point also with D-cycloserine is that there has never been really timing or dosage studies being performed, and so we have now accumulated a lot of information from the several studies, but it is all been trial and error.
Okay.
Yeah.
Okay.
Yeah.
And after these results, do you think that CRT, cognitive remediation therapy, or even CBT in itself is a better cognitive enhancer than the drugs?
Yes, definitely. So if I'm honest, I think the point is to augment, to find a clinically significant effect on top of the really relatively large effect of CBT or CRT or all these metacognitive approaches. If you carry them out appropriately and bravely, because it's sometimes very difficult to get patients in the mood that they say, okay, now I'm going to start. Then you already have induced such a large effect that if you want to have an effect of your cognitive enhancer on top of that, you must be really good at it. Yeah.
Thank you very much.
Yeah.
Can be in Portuguese.
Yes.
Carolina will translate for you. Yes. 5 minutes. Como a gente teve esse atraso da manhã, a gente vai quebrar um pouquinho o intervalo, em vez de fazer meia hora de intervalo, a gente fazer 10 minutos de intervalo.
Yes.
10 minutes instead of 30 minutes. Yeah. 10 minutes of interval. Eu gostaria de agradecer, já que eu não na chegada, né? O pessoal que eu não sei como é que tá falando agora, não lá, né? Mas tem a presença aqui do professor Giovanni, professor Wilson, não é mais professores por aí, né? A gente tem também o pessoal da neurologia da PUC, né? A professora André Palmini liberou vocês das atividades lá, vieram curtir aqui. Tem gente da UBRA presente aqui, né? E agradecer a presença dos professores, alunos, a Cristiane, que veio mais canoas também. Agradecer principalmente o pessoal da Liga de Psiquiatria, né, que nos oportunizou, por exemplo, a transmissão ao vivo pelo YouTube. Ninguém sabia que dava para fazer esse negócio aí. Eles descobriram. Então vai ficar gravado, tudo que fica gravado lá no YouTube, no canal da LipSub, que ali a gente quer ser documental. Daniel, o pessoal que está ajudando aqui. E agradecer também o pessoal da Rede Gaúcha de Pesquisa em Toque, que está aqui representado pela Laura, praticamente, ela está no PEL, né? Desde Pelotas dá o quê? Desde Pelotas para participar do Simpósio. Então é legal a gente nomear e agradecer. Não sei se esses caras não contam que obrigatoriamente tinha que estar perto. A vida pobre para fazer nada. Então a gente vai fazer os 10 minutinhos de intervalo. Agradecer de novo a presença da professora Helena, né, que
agradeço a presença de vocês e a liderança nesse processo de internacionalização que a gente vê no grupo com o professor Igor, a professora Ana Luísa, a professora Carolina.
Então, terminas. Vai.
Okay. Would you like? Yeah, I'll go to the bathroom and I'll go.
No caminho. Eu posso passar a lista e a gente faz isso. A gente passa a lista que nem no colégio, assim, bota um ok do lado. Pode também. Pagou igual, né? Pagou? Tem direito a certificar. Well. Vou entregar para ela o certificado já. Depois da Deixa eu apresentar para vocês a doutora Ana Cristina Kitzmann. Ana Cristina Kitzmann is a colleague at the Anxiety Outpatient Service at the Hospital Materno Infantil Presidente Vargas. She is a coordinator of the Anxiety Outpatient Service, my colleague there. I would like to announce also that we have the chief of the hospital here, Dr. Claudio Meneghello Martins. He is our head in our service of psychiatry, where we work with the students and the residents of psychiatry, and sometimes master and doctoral students also. They make some kind of experience there. And Cristina works there with us. She is child psychiatrist, children and adolescent psychiatrist, and she's preparing her PhD thesis about ethics and things like that. Okay, thank you very much, Anna. Go ahead.
Now, we will start the second part of our meeting. The second lecture, entitled Genetic Epidemiology of Tourette and Obsessive Compulsive Disorder. I will invite Dr. Daniele to start. We will have 40 minutes, 45 minutes to the lecture, and about 15 minutes to comments. Dr. Igor will make the comments, and then we will open for questions.
Thank you very much. In this second part of the lecture, I will talk about something completely different. So we now have to make a sort of a mind switch in our brains. And I'm going to talk about the genetic epidemiology of tics, OCD, and hoarding. And now, what do you do with genetic epidemiology? If basically that is twin and family studies, and there's no lab, no blood drawing, no molecular biology involved at all. So it doesn't teach you anything about which genes are involved. It doesn't teach you anything about the function of the genes involved in psychiatric disorders, but it gives you actually a sort of a helicopter view that is like really that you're driving or flying high above your data, and that can give you something of an idea about which proportion of the variation on the trait is explained by genes, which proportion of the variation is explained by environmental factors. And it also can tell you something about whether in general the similar genes are involved across the several disorders or it's different. It can tell you something about differences between men and women and all these kind of things. But it's basically something really different from molecular biology. And normally in genetic studies, you start actually with genetic epidemiology just to see what is actually the importance of the genetic part in the disorder that I'm interested in. So that's the way you should see this genetic epidemiology. Can I go to the next slide? Okay, so I'll first tell you something about commonalities across hoarding. So in prevalence rates, what we found, OCD and tics. I'll tell you something about the Netherlands Twin Register, in which all the studies have been conducted. And I'll tell you about the individual heritabilities of hoarding, of OCD and of tics, and something about shared genetic, the shared genetic components and the non-shared genetic components. So about the three of them together. Okay. As we all know, hoarding, do you get to see people with hoarding here in the hospital? Yeah. It's a sort of, it has been a sort of a hidden disease for quite some time, but since the DSM-5, we are more aware of hoarding than we used to be. So, because hoarding was not in the DSM-4, it first appeared in the DSM-5 as a separate category of disorders. And actually they have increased comorbidity rates. And also they have somewhat shared dysfunctions in brain areas in cortical, striatal, thalamo, cortical circuits that are there. So as you might know, you have this is a very simplified picture of circuitry involved in motor planning and motor behavior. It's the circuit that's more on the left. It's a sensory motor and premotor cortex that drives it. And then you have the cognitive circuit or the associative circuit, and you have the limbic circuit. And actually they interact more with each other than we originally thought. We originally thought you have 3 CSTC circuits, so from cortex to the deep brain, thalamus, and back to the cortex. But now we think we have these 3 parallel circuits, but they also interact with each other. Can I have the next slide? And what you can see in these circuits, you saw in the last time these colors. And actually you have the sensory motor loop, and that is from the primary motor sensory motor cortex through the putamen, through the pallidum, and back to the cortex. And that is actually the loop that's mostly involved in Tourette disorder. You have the cognitive loop with the dorsal lateral prefrontal cortex being inhibited in OCD, and you have the limbic loop that is very important, the orbital frontal, in decision making in hoarding disorder, but they interact a lot, of course, as well. Okay, next slide, please. Hoarding is actually, involved both in OCD, ADHD, a little bit in autism, but also in tics. It's a very interesting disorder that links a lot of disorders together. Okay, next loop. So if you want to look, what do they have in common? It can be wise to do twin studies, because twins are actually, they are, how do we say it? They're an experiment of nature. We're there. And actually they make use of, on a trait, differences in commonalities between monozygotic twins and dizygotic twins. That's actually the core of twin studies. So they compare variants, covariance between the twins of one twin pair in monozygotic with dizygotic twins. And the idea is that you have three causes of variance. And one is genetic, one is the common environment. Well, what is the common environment in people? in twins? What do they share? Family, eh? It's the family environment. And then there you have the unique environment. And those are the experiences that one twin has and that the other twin hasn't. I mean, when you are in a different class, when you are involved in different sports, when you have different friends, you have all kinds of things that you experience and that your co-twin doesn't. And that's the unique environment. And when you have a monozygotic twin, the genetics is the same. They share almost all their genes. There's some discussion about, but they share, let's say they share all their genes, but they also share their environment because they have been born at the same time within the same family. And the assumption is that they share the same environment. You can debate that because I think that in different twins, the mothers and fathers treat the twins differently because those twins are a little bit different and the interaction is a little bit differently. But the assumption is that that's equal and that it's unique environment that makes them different. In dizygotic twins, they only share 50% of their genes, but they share the whole common environment and they have these different environments. So the idea is that you calculate correlations between twin 1 and twin 2 with respect to their, the A stands for genes, additive genes, common environment and unique environment. And you look at those correlations and can I have the next slide? And the idea is also mostly with yeah, how do you say it? With a yes/no traits. So you say, okay, above a certain threshold, you have the trait, and below it, you don't have it, but you assume that underlying there is a liability threshold model. So it has a normal distribution, the trait, and you only say, okay, above this percentage, it's there, and below it's not there. And so you make your modeling based on that. Can I have? And it means, and you do that by structural equation modeling. I think this goes a little bit too far, but the idea is that that you look at a model in which actually you explain the trait by looking at the proportions. So you said, say the variability is 100%, and you estimate the proportions of genetic liability and of common environment and of unique environment. You can do that based on what you assume from comparing the monozygotic and the dizygotic twin pairs. Okay. And I'm going to talk today with you about 3 papers that we published on this. We published on OCD, on hoarding, on tics, and on trivariate analysis, in which we looked at whether, for instance, OCD in twin 1 could predict hoarding in twin 2, tics in twin 1 could predict OCD in twin 2. These are a little bit more complicated analysis, but they're all based basically on correlations in traits between twins within a pair and across pairs. Okay, next slide, please. What do we know up until now on hoarding? What you see here, these are previous studies on hoarding. And previous studies have all estimated heritabilities. Actually, the light blue bar represents the proportion of variation explained by genes, the red bars by common environment, and the purple bars unique environment. And the first studies of Ivanov, they have been done in a sample of 15-year-old twins. Then there's the third study by Iervolino in 55-year-old women. And by Taylor, it has been also done in children. So the only study that has been done in adults has been of Iervolino. And what you actually see, and that is what you see in most twin studies, is that there's actually no variation explained by family environment. That's very, that is actually something that we hardly take into account when we treat people, because actually when we treat people, we always assume it's because of your youth, because of all the life events you've had there. But if you think of those life events, even within a family, as being individual specific life events, because if you have been treated badly by your parents as a twin, it doesn't necessarily means that your co-twin has received the same bad treatment. Then you can explain it. But it is still a remarkable finding, because the influence in the long run of family environment is not that big. And actually come up until heritability percentages that are someone like up to 30, between 30 and 40%. And there's one very remarkable study in these 15-year-old girls by Ivanov that says there was, in those girls, hoarding is not explained by genes at all, but by common environment and by unique environment. But that's just one finding. It's very unusual and we don't know how to explain it. Can I have the next slide? So what we did in our Netherlands adult twin register, we worked on hoarding and OCS, and so obsessive compulsive symptoms, because in the twin register you always work with self-report. So you never establish a diagnosis by clinical interview, but you work with self-report and you establish cutoffs. And we know of the checklist we use, how high the points are that patients score on average, and we base our cut points on those clinical scores. But of course they're an estimate, so we'll be a bit reluctant to talk about diagnosis, but we like more to talk about symptoms. Okay, and what did we in the first place aim at? We wanted to look at, in our sample, hoarding and OC symptoms. It was an adult sample. Do sex differences play a role in OCD and in hoarding? What would you guess in hoarding? Are there differences between men and women? No, you think, okay. Yeah, I would have the same impression. I would also think that. More men, eh? But, well, it's good to investigate that. Are there more men? It's and that is really very crucial. It's an immense clutter. People are not able to categorize or to order. It's really, if you ask them, can you find for me this and that, they say no. I have no idea where it is. So, and that means that the word for that is clutter. So there's clutter, acquiring, and inability to discard. Next slide, please. These were the lists that we used. So we had only 4 questions on hoarding. So do you have difficulties in using your rooms due to clutter? Huh? Can you still sleep in your bed? Can you eat at your table? Can you cook? Many people cannot cook because the kitchen is filled. With collecting, and do you have any emotional distress? That is the funny thing of hoarding, is that mostly it's people themselves who have emotional.
This one, don't like.
No, he doesn't like me. No. No. Mostly, as you might also know, it's not the people themselves who have that much emotional distress, but it's their family, their friends, their children who say, I'm not going to visit you anymore. And they're themselves, they say, well, it's still okay. So, and we used the Padua inventory, an abbreviated version, tapping on checking, on washing, on obsessions, and ordering, and repeating. And these were the lists that we used. Next slide, please. And first we were interested in prevalences of these disorders. And of course, when you do only self-reporting, you get a little bit of an overestimate of scoring above the cut point that we say it's probably a disorder, because actually you don't ask so much for distress. We did ask one question in the hoarding questionnaire, but we didn't ask in the OC symptom questionnaire. So you get an overestimation, but what we found is that the scores on hoarding were almost 7% of the entire sample. The entire sample was, I thought, in the end of their 30s, scored above the threshold for hoarding symptoms. And for OCD, it was about 5 to 6%. Whereas in the general population in other studies, it's 3% for OCD, and it's about a little bit lower. It's about, depending on the age of the sample, it's about 5% for hoarding, between 3 and 5. And I'll show you, hoarding intensity and also frequency increases with age. Huh? Hoarding is in fact an old age people disease. Very interesting. I'll show you some data on that. Okay, next slide. Here, what we saw, because we had an age range between 15 and 90 of our twin samples. Because in the Netherlands, we have a register, and it goes as follows. Every twin can register with a twin register, and they get presents, they get twins days and twins days in which they all have to wear the same dresses or the same suits. And when you are a mother and you give birth to a twin, 3 days after the birth, you get a present of the Netherlands Twin Register, inviting you with your babies to join the Twin Register. So it's really a sort of a movement to be a twin in the Netherlands. It really helps. So we have twins between 0 actually and 90, but we used the adult register. They are between 15 and 90, and what we saw is the frequency of hoarding really went up after, you can see it mostly after age 45, something like that, but also the severity of hoarding goes up with age. And so it's not very reassuring for us, for me at least. I thought, well, okay, next slide. And what we found of their relationship, 16% of the hoarders had an OCD above the cut point, and of the people who had OCS, it was about 19%. Now in the DSM-5, hoarding is regarded as a completely different disorder from OCS, but we must realize that that is not the entire truth. Actually, you have a subgroup of hoarders who is really associated with OCS, in whom their primary problem is inability to discard because they're afraid to discard, to throw away something that is important to them. And they want to check it. So there is this group clinically, always ask a hoarder still ask him whether he also has OCD symptoms. Okay, and what we found is that we looked at the hoarding only, the OCS only in the hoarding plus OCS group, and what you see is that the hoarders and the OCS plus hoarders were a little bit older, and the OCD group was a little bit younger. Okay, next slide. When you then look at the individual heritability estimates, hoarding, we had the variance explained by genes was about 40%, and by unique environment about 60%. In OCS it was exactly the same, 0.4 and 0.6. So actually the majority of the variance is explained by life events. So I think we should perhaps really study environmental influences through development much more, instead of focusing all the time on genes. We must realize that. Okay, next slide. Next one. So for the first part of our talk, of my talk, I want to say about 7% lifetime prevalence we found of hoarding, but we had a lot of old age people in our sample. Yes, we had. Oh yeah, I forgot to tell you that these 3 symptom dimensions, clutter, acquisition, and inability to throw away, were very highly related. Almost all patients had all 3 categories. We found more than 80% of the people endorsing in all 3 categories. It's very rare to have a patient with only one category of hoarding. Okay. Symptoms, increase in symptoms with age, genetic influences. Yes. Okay, that's what I wanted to tell about hoarding. Now let's go to the tick twin studies up until now. There have been a lot of twin studies. There's mostly again in children, very remarkable. There had only been one study by Pinto in the Swedish twin register on ticks in adults. All the other studies, Oki has been a Japanese study, Bolton, Liechtenstein, and Ankasat are all in children. And what you see in general is that genetic influences in children are always a little bit higher than they are in adults. In adults, the environment comes in. As we grow up, we are under much more environmental influence than when we are very, very small, of course. And what you see there is actually, as opposed to what we used to think of ticks, we always thought ticks are very heritable. But in these epidemiological studies, they're just equally heritable as any complex behavioral trait like anxiety, depression. It's even around 30%. Only Liechtenstein found a somewhat higher heritability. And in one Japanese study, you find a family environmental factor, which we couldn't explain except by cultural differences between the traits. Okay, next slide. So we went to look at tic symptoms, and we had all kinds of tic symptoms, eye movements, head shaking, shoulder or neck movements, but also throat clearing, coughing, sniffing, cursing, coprolalia, and we also asked to have some DSM-4 criteria. We also asked whether there had been suffering, age at onset we asked, and we asked about frequency of the tics. Okay. And then we defined 4 tick phenotypes because we were interested in how much difference it would make if we would if we would be more strict about the phenotype and say no, it must only be Tourette syndrome. It means 2 motor tics and 1 vocal tics, or that we say we just include any tic and then look at heritabilities. So we had an any probable tic phenotype. We had TS plus chronic tic disorder, plus chronic motor tic disorder, and a lot of tic disorders, and as long as it was a disorder in terms that people were suffering from it. Okay, next slide. And then we found that during their lifetime, so these were all 35-year-old people, about 12.5% self-reported. You can be very critical about that, about having had experienced any probable tic. That about 1.6% reported to have had probable TS or probable chronic tics, and 1.3% chronic motor tics. You know, in epidemiological samples, the prevalence is a little bit lower. It's about 0.8%, but 1.3%. We thought for a self-report, this is actually not very bad. It's a lifetime tic report, so we thought, well, we might be more confident about our self-report estimates than we were when we started this study. Okay, next slide. And we found the heritabilities that were actually the lowest for the most strict phenotype. There were about 0.25, so 0.75% was explained by unique environment. And for the any probable tic diagnosis, heritabilities went up, which also might have been the consequence of that we had higher power to detect these heritabilities. Okay, next slide. And what we also found was that the confidence intervals between all these definitions on the heritability estimates overlapped, so that by and large they seem to measure the same thing. Okay, why do I say that? Next slide, please. Why is this important? So we had a overall 0.3 heritability, which is not very high. We had overlap between all these phenotypes. Actually, what we pleaded, not all the reviewers were very happy about that, is that you don't have to be too strict about this tic phenotype. It's actually, so the addition of age at onset, of frequency of tics. So for the DSM-4, you must have an age of onset of your tic below age 21. The second thing is you must have a frequency of tics. You must have at least 2 motor tics and 1 vocal tic. We didn't find any reason to do it that way, because the any tic phenotype, in which people could just name any tics, did just as well in the genetic analysis as the other phenotypes. So we said, well, instead of being very strict, perhaps in genetic studies, you don't have to be that strict to still capture the phenotype well. Okay. Hey, this is strange. The conclusions, oh no. Yeah, So there's the contribution of genetic factors is more modest than we thought. There's a continuous liability for having mild or severe tick symptoms. Okay. And let's now move to the next slide. Yes, hey. Yeah. And that is the study in which we combined them all. So we end up with hoarding prevalence rates in the twin register of 6.7%, 5% for OCS, 1.3% for Tourette, and very high levels of any tics. And then we started modeling those 3 phenotypes. Okay, next slide. This is a little bit of a jigsaw puzzle. So we found 16% of OCS in hoarding, 9% tics in hoarding, 90% of hoarding in OCS, as I told, and 12% tics in OCS, 23% of hoarding in tics, and 27% of OCS in tics. Thank you, Igor. And what did we find in the heritability estimates? Yes, I'd like to have the next slide. Actually, what we saw is that in the model fitting, we thought that there was actually most of the evidence of one shared genetic and several unique environmental influence to best explain the relationship between hoarding, OCS, and tics. So in all 3 disorders, prevalence rates of the other 2 disorders are increased. And we found that there's reason to think there is a shared or a set of shared genetic influences. When you look, for instance, at the genetic correlations, you see that the genetic correlation between hoarding and OCS is 0.4. So that's really very, very quite high. The genetic correlation between OCS and tics is also almost 0.4, and between tics and hoarding also around the range of 0.35. So those are the correlations already. They are really significant. And the next slide. So it means that about 40% of the total genetic variance is shared across hoarding, OCS, and tics. And that, well, it leaves still unique genetic variance for each phenotype between 50 and 60%. And also there was something very interesting, that there was a lot of range in the shared environmental variance. The environmental variance that explains why people develop hoarding or OCS was also about 40%. But between tics and hoarding and OCS, there was hardly any shared environmental variance. And that means that to acquire tics or severe tics needs a completely different environment from acquiring OCS or hoarding. So genetically, there are similarities, but environmentally, between tics and OCS and hoarding, there are not. So the next step would be to look at these differences in environment, why people get tics and they don't get OCS or hoarding. That was actually, I found that very interesting. So what does it mean? These are the genetic relationship in the next slide. So these are the environmental relationship. Hoarding and OCS share parental rearing, or in what kind of environmental things you think of, but tics don't. Next slide. Oh, and that is what that was what I wanted to say about it. And this is the group of the European grant that we acquired, in which we have investigated all this. And to the left under, we are talking about collaborations. This is our Portuguese PhD student who has conducted all these genetic epidemiological analysis. His name is Nuno Nogueira. He's from Porto. So what I would and the PhD student standing next to him, she's Riette Oldman, and she was helping him with the tick analysis. And of course, you might know Carol Matthews. She's from Florida now. She used to be in California. And Kevin DeLucchi is a statistician who is working with her. And that's what I wanted to tell you about these a little bit complicated genetic epidemiological analysis. I think we are in time with this talk. I have a question to you. Do you have a twin register in Brazil? And also not a clinical twin register. Do you ever ask your patients, are you part of a twin? Yeah.
In São Paulo, Priscila, a PhD student of Euripides, USP, she's trying to collaborate with a kind of twin study in two-head syndrome and then OCD, but she's recruiting twin pairs, but it's not so easy. Some years ago, she came here to Porto Alegre and interviewed 3 pairs of twins that I knew. I took them to their houses to make the interviews, but 3 in 10 years, I think, so here in Porto Alegre. So it's, we can say we don't have twin studies in Brazil. It's really difficult to perform that.
You have a very large, a very nice consortium.
Yeah, but you don't have this culture. And
no, but you have
there's some advantages of a small country. Brazil is continental. It's really difficult to perform research involving that. And our public system of information is not so good. We don't know when a twin pair is born.
No.
Yeah, we don't know.
But you
we have to
try and start a clinical twin register, and perhaps across all kinds of disorders, because the nice thing of twins, especially of monozygotic ones, is that it teaches you a lot about the environment that makes one twin different from the other.
Yeah.
We could help you with that.
Daniel, Galus.
Yeah.
Daniel and Daniel. We have Daniel.
Yeah.
Behind you.
Yeah.
Well, I will do some comments, and afterwards I will open to the audience to some questions. First of all, I would like to congratulate you for a nice lecture. Really complex for us, for me especially, as I told you this morning, genetic is not my beach. Yeah. Não é minha praia. I told her what the meaning. She's coming from Praia do Rosa, so she knows the meaning of praia. And genetic is not my, but I am a clinical psychiatry, and many things you told us, I think have relevant clinical practice. For example, when you talk about the genetic aspects, molecular genetic aspects, what importance does it have for us that we are with the patients? For example, if I know that her mother have OCD or a tic or hoarding disorder, and she also has, for example, and if I know what's the relevance for my clinical practice, it helped me to think on the treatment I will choose. For example, if her mother has OCD, and she is well with fluoxetine, for example, and she's coming to me to seek for pharmacological treatment, I will think to use also fluoxetine. So the genetic aspects, the molecular genetic aspects, for me, it has this kind of meaning. Nowadays, we don't have exactly genetic treatments, but in the future, I think we will have some kind of engineering. We can move some kind of specific gene to other side, and probably we will cure OCD, tics, or even hoarding. That it's much more complex, hoarding. When you talk about family environment, you said common environment or a family aspect. I always think about two ways of thinking. It could be easier if the family shares the diagnosis and they also knows we have no kind of bad thoughts about the disease. How do you say preconceito in English? Prejudice.
Yeah.
The family has no prejudice about that diagnosis.
Yeah.
But as they understand, the family may also accommodate. And that's not good. Christiane here works with family accommodation. If you have twins in a family with OCD or tics or hoarding, the family will be accommodated. And that's I think it makes a great influence on the performance of the treatment and even in the behavior that the twins or the family will have in the future. And when we talk about the unique environment of each of the twins, I think that's the point, makes sense for me, that's the point to specifically treat each one. For example, if one have OCD plus tics, severe OCD, and the other twin has just OCD, no tics and it's not severe, the treatment will be different, cognitively and behaviorally talking. So your approach in your twin studies is really rich for the treatment strategies that we will construct with the people. And it made me have a new vision of what we should investigate it when we are with our patients, even not being twins. We have to investigate the genetic because it can help with the treatment. We have to investigate the common or the family environment, and we should investigate the unique, the events, specific events that the people have in his life, because it's impressive, your results. For example, in tics, I would expect the genetic factor would be much more higher.
No.
But it's higher in
But it's
OCS.
not. No.
Yeah, incredible. In my head, I have the thinking that tics are much more organic, neurobiological than OCS and hoarding.
Yeah.
But your finding didn't show that.
But that's what everybody has been thinking. We were even thinking of autosomal dominant genes. But if you look at tics, you only find about a 30% family history in tics. And I think personally that tics are the most psychiatric of all neurological disorders. Because tics are very, as opposed to, for instance, myoclonus or Huntington or anything, they're very, well, perhaps all movement disorders are somewhat susceptible to stress. They increase with stress, but tics are very susceptible to stress. People can suppress tics very well, depending on the context where they are. So this suppressibility, the increase with stress, and what you see a lot with tics is tic-like behaviors that you could interpret, in fact, as psychogenic or as functional, as they call it in neurology now, or as conversion. And it's it's what we cannot say, but it's really. how do you say it? It's absolutely a disinhibition problem that people have that is neurological, biological in nature. But on top of that, there are many factors that aggravate it, that can diminish it.
Rosalie Chaviti,
Yeah.
in her PhD thesis, she showed that Tourette patients respond to clomipramine. Make nonsense if you think that tic is only dopaminergic, but
Yeah.
it's not also only dopaminergic. We have a kind of psychogenic tics, perhaps, probably. But it's interesting and impressive is that it's possible in Netherlands to have 5,000 pairs of twins. For us here, it's incredible, impossible, almost impossible.
No,
so
no, no.
the results are
Nothing is impossible.
yeah, unquestionable.
Even in Brazil.
Yeah, Gabiru já fez isso. Well, another question that I have for you is that the dimensional approach, I understand that it helps us to understand psychopathology very well. But do you think the dimensional approach may also help us to treat patients? I know, if I understand psychopathology, I probably will treat better. But I don't think dimensional approach is enough to help me to decide, oh, I will treat with CBT or risperidone. I don't think categorical approach has its role in the therapeutic decision.
Yeah. Well, still, it is very useful for clinical practice, the categorical approach, of course. But, oh, no, this is...
Yours. Not mine, I don't have. For sure. Hoje de manhã, se eu tivesse, facilitava um pouco a minha vida. Mas, né?
No, but it's a difficult question. If you say
I know
the dimension, I think for explaining to patients and their families that, for instance, the hoarding symptom in their child who has no tics is somehow biologically related to the tics of the parents, that can be very revealing, and it can be, people can be relieved by the fact that there is this heritability factor involved, and that it's not something in the upbringing that they have specifically done very wrong. That it's just this susceptibility of this child to develop. For instance, I didn't show, we also have a lot of family data showing that in relatives of tic disorders patients, especially with respect to OCD, the women of the families, they are much more prone to get OCD, whereas the men are more prone to get tics. Very interesting. But we don't really have a biological explanation for that, other than that someone on the road between the same genes, because there are no qualitative well, up until now discovered differences, genetic differences between in tic disorders. So somewhere on the road between the gene and the expression of in the phenotype, there's something going on that men develop their tics. But men are in general more prone to externalizing behavior, and tics are externalizing, and OCD is internalizing. But if you explain to the family that the basics is, at least you can de-guilt them a little bit. But then you say, okay, and now the next step is how are we going to diminish your symptoms? And then I always focus, but for simplicity, on one disorder or one symptom at a time. But that's, if you mean that by a categorical approach, okay. But if you know that a person has tics and OCD, we know pharmacologically, then it's wise to combine an antipsychotic with an SSRI.
That's it.
It will be more fruitful than only an SSRI or only an antipsychotic
Yeah.
normally.
Yep, it's
So
really
it
complex.
helps you in these kind of things.
Also,
Yeah.
in the OCD world, the people
Yeah.
likes OCD, not everybody, but we are talking about the heterogeneity of OCD. OCD is not only one disorder, but a group of disorders. Do you have in your data set something like, for example, aggressive symptoms, symmetry, ordering, arrangement symptoms to compare twins with, for example, contamination, washing, dimensions?
Yeah. Well, we have those data because we have this Padua that I showed, but we didn't look for that. So you would be interested in whether if twin 1 has washing, whether the odds are increased that twin 2 gets checking, for instance. Or
because it would be nice to investigate. Although we don't have one patient with only one kind of symptom, or only with one. Yeah, we have multiple symptoms, but the most prominent dimension could be investigated. But it's just one idea. As in the OCD world, we are talking about the dimensions. Seisa did that, and Jim Lackman, the DIBOX, Dimensional Yale-Brown Obsessive Compulsive Scale, and we are investigating specificities of each one of the dimensions. And you have a data set great enough for this kind of investigation, but it wouldn't be easy to do that. But I don't think you have the DIBOX. Probably you have DOCS, DOCSS.
No, we have
Damian Dennis.
DIBOX.
DIBOX?
Yeah, well, actually, frankly, we now use a lot more the OCR.
Oh, sorry, OCR.
So that is 18, because it's very, very long, the DIBOX.
That's it.
Do you use it here?
Christiane works with that. Okay.
Yeah.
Thank you very much. We have some time for questions. If you'd like to have some question, Luisa, Giovanni, go ahead.
Okay, actually is a question about your data applies to the individual. I mean, the data explains the variance explained by genetics or the environment, but can I apply this to a specific individual? For example, I'm going to see a patient with tic disorder in this afternoon, and if he says something like, well, you know, I think my problem is genetic because I try many things and I think that's all biological. Can I say to this patient with some degree of certainty, no, I just went to a lecture and now I know that this is not true. The point is not genetic. The point is environmental.
I think it's a wonderful question, actually. It's a very complex question that you ask. You know,
actually, my therapist said that this was my homework for today. I suffer from social phobia.
No, but it's a wonderful question because it's very much misused, these data on genetics and environmental contribution to the variation within individuals and between individuals. And that already says that you can never say, you can say to your patient, in general, there is a substantial environmental contribution. But for your individual case, it might be that genetics does play a more important role than environmentals. Because you can never, it's not a one-to-one add-up system that has led to our present data. It is a large heterogeneity between the individuals, between these 15,000 people, that cumulatively, so adding everything up, has led to this But there might be people in whom the contribution has been entirely environmental, who've acquired the tic by copying others, and people in whom it was very genetic, but it led to an overall estimate that is quite robust because we have so many individuals. But you can really, I would not be too antagonistic to your patient because he might be right. But you can say, I would always say, listen, tics there is an environmental component. There is a stress relationship with having tics, especially with the severity of tics.
For example, you can say genetic defines you, but you can change it.
Yeah.
Genetic may define your behavior or your appearance, but you can change it.
Yeah.
Or not.
No,
Or not.
I would always say
Or not.
it's interaction. It's in an interaction between environment and genes and vice versa. Yeah.
More questions? Os residentes. Thiago, tinha questions? Era do outro assunto. Laura? Eu conheço alguns, é fácil chamar pelo nome, né? when we know the people, it's easy to call by name.
Yeah.
Well,
but I want to say some more thing about this genetic thing. The thing is that now we are moving from the first step is there genes involved? Yes, there are genes involved, and then they do all these molecular researches with genome-wide association studies, etc. These genome-wide association studies, they find a SNP. We have a lot of SNPs, more than 3 million, I think. No, more, 3 billion, I think. And then they say, okay, that's related to the disease, and the explained variance is less than 1.11%. And everybody says, well, what's the meaning? But sometimes this same SNP can lead to a druggable target, to development of medicine, of a pharmacon that's very important to treat the tics. So don't be desperate when you see all these studies and you think, wow, what do I need to do with it? But the end goal is, of course, to find one SNP that really can change our treatment.
That's it.
Yeah.
Very nice. Carol? Yeah, here.
So I always have a question. So
yes, very good.
Congratulate for your talk. It was very nice. And when I was looking to your data, I was thinking about the data that I have work with panic disorder. And I have this idea that maybe we are looking to the wrong side. We are doing a lot of studies related to genetics, and I think that we should look to this other side, which is the environmental factors. And I remember a very interesting study that was done with depression in twin studies, and they found that having a bad emotional relationship experience was the factor that interfered, that was associated with one twin having a depressive disorder and the other one not having. So I was wondering, what about having your data and using technologies like machine learning to take which factor will be related to each disorder? So maybe we should do we should analyze the data with the technologies that we have been learning with genetic studies, but to look to environmental factors.
Yeah, that might be possible because what I think that we should take into account with environment is so it's these unique experiences but also the development of them. Mm-hmm. So at what age did what occur? Mm-hmm. Because I think you have ages in which you're much less vulnerable to adverse events than other ages. Mm-hmm. It seems, for instance, that around the transition, in Europe, the transition from primary school, which is very safe, one teacher and every time the same class, to a high school in which you have to take care of yourself to get yourself in the right class with the right teacher every time. That is an age in which stability of your family background is much more important than when you're 16 and you're drinking with your friends, and your friends are much more important, and what happens there. So if we could think first of collecting data using a model that takes into account, that we understand a little bit better what is bad at what age of development, that would also get a higher quality of our data. But on the other hand, what you're saying, the twin register gathers every 2 years of all these adolescents and the children growing up a lot of data. So it's a good idea to think of what stressors we would be interested and whether we should first look at what age it seems to impact most on depression, for instance. Or, well, it's a bit of a long answer, but my story is genes, environment, and development, actually.
Wilson.
First of all, congratulations for your presentation. Thank you, Igor, for inviting me. I would like to know if another subject about schizophrenia. Do you know if did increase the rates of incidence of the schizophrenia in Netherlands since the legalization of the cannabis?
No, it didn't. Not at all. In the Netherlands, it is completely stable since the 90s. Yeah. But in the meantime, we also know that, and that was surprising to us, that cannabis use is a stepping stone to develop schizophrenia. And we know that from twin research, in which one of the twins, MZ twins, was using cannabis and the other was not. And that the cannabis user has a much higher risk to develop psychotic disorder in time than the other one. But the prevalence in the Netherlands, no, has not increased with legalization, no.
Because tourists use it.
Yeah. Well, well, the funny thing is that it's partly true. Yeah. For
the Dutch don't use, the tourists
well,
use.
we do. I have two sons. Have had. It was not really a pleasure to bring them up in Amsterdam when they were adolescents, but no, but they are that it's a time period in which they experiment, but they stop. Then they say no, it interferes too much with my. Yeah.
One more here.
Can I ask you a different question?
Yes.
It's about CRT in OCD.
Oh, nice.
Could you talk a little bit about this? Because I see in your protocol and I want to understand if it's a training, CRT.
Yeah, we did it. Yeah, we did it in eating disorders, in anorexia, presuming that, there's, and in OCD and in people with both. And we did, let me see, something like 65 OCD, 65 eating disorders patients. And we did CRT and we compared it. And the CRT we did is that we did it in a very conventional way. So first people get, do you know about cognitive remediation therapy?
Almost nothing.
It is a therapy that focuses on improving the cognitive flexibility of OCD patients. So it is not about OCD symptoms themselves, but about the way OCD patients do things. They do things mostly in a very rigid way, very habitual, inflexible. So they will, and the thing is that they are always focusing on details instead of on the big picture. That's the other part. And so it's these two things, improving cognitive flexibility, and we do it first by, for instance, we give them a Rye complex figure test to fill out. So it's a complex figure that you have to draw. First you draw it from the picture that you have, then we take away the picture, and then after 5 minutes we say draw it again. And we don't focus on the mistakes they make in making the new picture, but we focus on the way they do it. So we ask them, some people do it in a very detailed way, and some people do it in a more global way. They first make the big picture. We do the same with the Stroop. We do the same with all kinds of trail making, all kinds of tests in a little bit, and the talk that we have as therapists is about the way people think. And then the next step is that we generalize that to the daily lives that the people have. So we say, in your daily life, how many times do you, for instance, use another routine in cooking? How many times, how many routes do you use to go to the clinics to visit us? What do you do when you dress, or when you, and can we think of a way that you deliberately go in 4 different ways to the clinics and back? Or even though it is uncomfortable with you, or even if it's, so we try to make them aware about the rigid ways they do things. That is actually the essence of the therapy.
Very interesting.
But what we had a control condition, because we thought, well, you always find an effect, and you think, well. And the control condition was that the people also came twice a week for 3/4 of an hour, 10 times. And then we just did a game with them, but not a game that stimulated flexibility, but other kind of games. And the homework that they had to do was to do a game at home, some sort of board game. The point was that actually both therapies worked equally well, and the people were in both conditions very glad that there was now a therapy in which they were not inclined. They were not allowed to talk about their problems. They had to talk about how they think in one condition. The other way, they were allowed to do something pleasant.
It's not the same of schema therapy.
No, completely
No?
different. Yeah.
Similar? No?
But what I think, what we would improve in the next time is that we would even more personalize it, really fit it to the person's needs and his daily problems with. In OCD patients, goal-directed behavior that is flexible, that requires more energy, is very rarely done. Like for instance, you have to, you have to work, and in the meantime, there's a child or there's a friend of mine that needs to be picked up. So you arrange something while you are working. These kinds of things are very difficult for OCD patients, this flexibility.
Very nice.
And that's what we train.
Giovanni and Wilson, do you know CRT?
And the idea is that it helps in
you can teach us.
Yeah, we have.
You can teach us.
We have, yeah.
About?
Yeah, well, that both treatments worked, but in fact, what so-called placebo or control condition was equally well as the CRT condition. And what we did it preceding the CBT, and what I would now, in the next step, want to do differently is that we all the time refer to the CRT in our CBT. So when you devise a symptom-based thing that people have to, that you think, you were able to change your behavior, and you were,
Very nice.
Yeah.
Cristiane, sabe fazer? Not yet.
And we can send you the protocol if you want to. Yeah.
Very nice. Interesting. Makes sense. for OCD and for OCPD,
Yeah.
personality disorders also.
Well, in fact, you treat the OCPD
Yeah.
part of the OCD. Yeah, yeah,
Intersection of OC and OCPD is obsessive compulsive personality disorder, and it's an intersection with OCD of almost always, or many part of our patients, we have both diagnoses, OCPD and OCD. It's not so rare, not so uncommon. Rare is another thing. Well, we have to finish our symposium. We'd like to thank you very, very, very much. We were really pleased to have you here from Netherlands. So here tomorrow you have your cousin's event. But
Yes.
today was a OCD and cognitive enhancement event, and we'd like to thank you very much. And perhaps you will come back one day, or we will go to Utrecht to visit you
We'll
in our
invite
holidays.
you.
And we have some to certify you were here. Nothing complex, very simple. To improve your curriculum LATS. They don't have LATS in Netherlands. We have a kind of public curriculum here, academic. Yeah. Okay, thank you very much. Let's thank her. Yeah.
No, it's wonderful.
Oh, great.